Okay. Hi guys, good afternoon. Thank you for joining us on this Saturday. This is the third session of our webinar, and this webinar will cover what we have learned, where we will present cases to all of you, and then we will discuss. So this discussion, I like it to be two-way, and I like it to be more interactive. So please do put into the comment so that you can tell us what you think about it. Okay, so this present. So this 40-year-old gentleman was admitted for shortness of breath of sudden onset. He is a smoker but no history of hypertension or diabetes and no family history of coronary artery disease. Now from this chest x-ray alone, what is your working diagnosis? And from there, where do you take the investigation to confirm your diagnosis? Anyone? So we have, okay, nobody? Nizar?
It looks like that there is, obviously what you see is actually cardiomegaly.
Yes, that's the most obvious thing. But if you look further, that's actually
bilateral pleural effusion as well. Looks
yes,
like
the pleural effusion, and then there's a lot of congestion.
Correct.
Okay? Yes.
There is the soft shadowing around the hilar, and if you look closely, I think you will see the veins in the upper lobes as well are filled.
Yeah. So upper lobe diversion. So this is a very typical chest X-ray of congestive cardiac failure when there is fluid in the lung. Okay. Now then an ECG was made, and please now what is the ECG? Okay, somebody said heart failure, true. So this is actually a typical picture of heart failure on chest X-ray. Now what we want you to know is, okay, from this chest X-ray alone, a diagnosis can be made, but then many other diagnoses can follow with this chest X-ray alone. So now we have given you another investigation, that is the ECG. Anyone? It's very simple. What does the ECG show? Maybe if I can allow to unmute all. Allow participants. So if you can participate, unmute yourself, and then we will go on from there. You can't hear anything? Somebody can't hear. Najwa said okay, so Aisha said AF, Fa said AF, which is very true. So from the rhythm itself is atrial fibrillation and it's very fast. Okay, there doesn't seem to be any ST segment changes to suggest ischemia or acute myocardial infarction, which is ST elevation. So we go on. So what are the signs you'll be looking for here? Give us 5 signs that you would look for in this gentleman. Okay, and then we would also like to see what are the differential diagnoses that you can make from this chest X-ray. And you have already given the diagnosis of ECG. And what are the questions that you may ask this gentleman based on this ECG, which is very important to what you will decide on how to treat this gentleman eventually. And what investigations, further investigations would you do? And what's your workflow going to be like as a house officer? Okay, so maybe you would like to tell us, is there left ventricular enlargement on the ECG? I think it's a very difficult, can you hear me?
Yeah,
Nizar? Okay. I think it's a very difficult diagnosis to make of left ventricular enlargement on the ECG by itself. Left ventricular enlargement would be made mainly from the echocardiogram. Okay, so maybe we would like, so what are the signs you're looking for? Now, when you palpate Okay, the apex beat may be displaced, and when you auscultate, there may be a murmur, gallop rhythm, bilateral basal crepitation. These all will help you confirm your diagnosis. And of course, because we see bilateral pleural effusion, we also may find that on auscultation, you have reduced air entry over the both bases, more so over the left base. I think the left base seems more the left pleural effusion seems more clear on the chest X-ray. Raised JVP, you like to see whether the patient has fever, bilateral ankle edema. Patients sometimes can have bilateral ankle edema for months, and then they don't come in, and then they come in with acute pulmonary edema. And always check the hemodynamics. So again, let's go back to what are the differential diagnoses from the chest X-ray? Anyone? Everybody is learning now, so it is quite difficult to actually get participant because we are not used to teaching from the webinar. Nizar? Nizar?
No, I think they are typing their answer, so you give some time to let them type.
Where's Nizar? Ahmad, Nizar is muted. Ask to unmute. Okay.
Can you hear me?
Yes.
Okay.
Okay.
I think it's difficult to get a response.
Yes, that's right. Parapneumonic effusion. What is the parapneumonic effusion? I think I never heard that term before, Sharifa. Okay.
You can get parapneumonic effusion because what you get is, let's say you have a pneumonia in the adjacent lobe.
I see.
Get an effusion at that site. Yes, you can get that. Yeah.
Possible. Yes. Atrial flutter. No, this is not atrial flutter. This is definitely looks like atrial fibrillation. I don't see any flutter wave. Alvin said bilateral pleural effusion. True, bilateral. So we look at the chest X-ray again. Okay, bilateral pleural effusion. There's no doubt. Okay, So this enlarged this cardiomegaly, I think more likely to be seen on echocardiogram to be confirmed. And atrial fibrillation for sure. Okay.
The question says, why look for fever?
Okay. Why look for fever? Because yes. Why look for fever is because one, we want to see whether it's myocarditis. So one of the reasons to look for fever.
You may even have a pneumonia that may exacerbate heart failure as well, because infection does that. So you want to look for signs of infection.
And of course, you have sometimes other infections like that, leptospirosis that can cause multi-organ kind of with a pneumonia, with heart failure. So yes, look for fever always. Okay. And then what else do you want to look at? Okay. So what are the differential diagnoses from the chest X-ray? Well, of course, we have already made the diagnosis of congestive cardiac failure, but we will also think of acute pneumonia. The left pleural effusion could be due to other causes, okay, but the causes of congestive cardiac failure is very important. So you like to look for signs or symptoms of coronary artery disease. We like to think of hypertensive heart disease, valvular heart disease, myocarditis, and cardiomyopathy. Yes, somebody did mention that cor pulmonale. Cor pulmonale, not likely. The reason is because cor pulmonale is more likely to be, how do you say that? Right-sided failure. So your left-sided failure signs like pulmonary congestion would not be there. Okay, so not so likely. We go back to this. Okay, these are the things that we would like to entertain. So we do have two things. okay, heart failure, and atrial fibrillation. Okay. So the diagnosis of ECG, very simple, fast atrial fibrillation. What are the questions that you may ask based on the ECG, and what further investigations would you like to do? Anyone? If you can unmute yourself, better still. Okay. Or you can type in if you want. We wait for a few minutes to see how people type in. This is also a learning process for us, like I was saying, that to teach. Yes, Qin Wing Yuan has said whether the symptom is less or more than 48 hours. But his symptoms is actually shortness of breath. And then when you have shortness of breath, which is acutely, you need to go on to ask whether he has other symptoms, especially palpitation, now that you have, yes, cough is one of the symptoms that you would like to ask. Very common, they have had cough for a few days or few months, and then suddenly they actually get acute shortness of breath. Okay, does the patient have thyrotoxicosis? Well, there's one diagnosis that you would like to entertain. Yes, any presence of optopnia, PND. So think of all the symptoms that you like to ask the patients and gather this like an evidence, okay, like you are solving a problem. And this then will help you establish your diagnosis. I like to do this even as a student, as a doctor, is to get a diagnosis before I go on to the investigations. So even the atrial fibrillation, you can get a diagnosis before the ECG, because when you feel the patient's pulse, it will be very irregular, okay, irregularly irregular. So these are all the signs and symptoms that you would like to gather before the diagnosis is actually made. So chest pain, yes, you like to ask him whether it's chest pain, optopnia, PND, profuse sweating, okay, any symptoms that is related to hyperthyroidism because you already suspected. Yes, loss of consciousness also, okay. Now this 48 hours of palpitation, because we say that palpitation less atrial fibrillation that is less than 48 hours, we would like to think of reverting them to sinus rhythm. But sometimes when you see a chest X-ray that has shown such big cardiomegaly, chances are it's very difficult to change them back to sinus rhythm, right? Nizar, maybe you'd like to help us there?
Yeah. The question here is, what's the cause of the atrial fibrillation? Whether the atrial fibrillation came first, or is it part and parcel of the underlying disease as well, isn't it? If it's the primary condition, atrial fibrillation uncontrolled can cause heart failure as well in certain situations. On the other hand, you may have pathologies that may actually cause both heart failure and atrial fibrillation at the same time. It's a good idea to think of it that way as well.
Yeah. So I think we go on to discuss, okay. Now this is an acute presentation. It is an emergency, okay. It's acute pulmonary edema. So you need to look at certain things to help you, especially when you are a house officer, okay. Because this is the time where you make a difference between, let's say, ventilating a patient because you did not, treat it fast enough, or the patient didn't come early enough, okay. So these are the things that you want to look at, okay. And then the blood pressure is very important because it will also determine whether how urgent it is, okay. Now it is very common, I see that a lot of people when they see a patient, they immediately set a line. They set a line, but worst thing is they put up a drip. Anyone who wants to say, and when you put up a drip for a patient with acute pulmonary edema, okay, chances are you're going to make it worse. Okay. Okay, I'm not sure who is actually talking at the background because I already muted quite a lot of people. Now, it's very interesting to note that you need to always come to a quick working diagnosis, okay, especially when it's an acute case, and establish the acute treatment from the history examinations and simple investigations. That is your job as a house officer. And then always think at the back of the mind the underlying causes. So in your mind, you must have a workflow. Okay, like, okay, this gentleman, so you must be quick. Okay, blood pressure, saturation in the 70s. Okay, what do you do? Okay, oxygen, do you give nasal prong? Do you give oxygen as a mask? Do you need to call the anesthetist to come and intubate this patient? Okay, if the patient is exhausted, you need to learn how to see how exhausted the patient is, whether the patient will be so exhausted that you have no way to actually do anything but to intubate the patient first. So I think that's all very important. Nizar?
Mm-hmm. I agree.
Yes. So what do we do?
One of the things that I've always found important is actually having an idea of thinking 2 steps ahead all the time, you know. So you're thinking of diagnosis, you're thinking of treatment, you're thinking of complications. You're thinking of diagnosis, you're thinking of underlying disease as well. And then you're thinking of how to treat the underlying disease. So always think 2 steps ahead, and that will actually, serve you very well throughout your medical career.
Yes. Our aim here is to save patients. And the faster you think, the faster you learn. That's how you become a better doctor. Okay, and 2 steps, 3 steps ahead, yes, definitely. So now our case management will be give oxygen, prop up the patient, venous access, okay, IV Lasix, okay, don't be scared to give IV Lasix because that would really help, okay. Now the fast AF, think of rate control, think whether you need to revert the patient, okay, but most importantly, don't think of just the sign or symptoms. Means, for example, in this patient, don't always think of just the AF, okay, think of the heart failure. Okay, think need for cardioversion or not. Or if you were to cardiovert, what are the chances of it being successful because the heart is so big? So what further investigations would you like to do? I would think that simple tests, blood tests, okay, cardiac enzymes and cardiac troponin T, definitely, because you want to know whether it's actually an acute coronary syndrome. But seldom do you have acute coronary syndrome in a young gentleman that comes with acute pulmonary edema, isn't it? Is it important to do an ABG? Okay, somebody asked. That's a very good question. Okay. An ABG can be done.
You can do a venous ABG.
Yes. Most times it's because if the patient is not exhausted and the patient is not going to be intubated, so most times I would not necessarily rush to do an ABG. It won't change very much our management. Everything you do should prompt you to whether it's going to change your management or not. So no, I don't think it's very important to do an ABG. Yeah. And then further investigations, how about echocardiogram? Echocardiogram, okay, some places of course will not be available, but when you have an echocardiogram, it is also very important to do. It will help you in the management of your atrial fibrillation because you want to know whether there's valvular heart disease or not. Okay, you want to know what's the LV function. If the LV function is poor, chances are you revert the patient is going to be unlikely to stay in sinus rhythm. If it's valvular heart disease, I think chances that the atrial fibrillation has been there for some time is also also important. So I won't rush into reverting the patient, cardioverting the patient to sinus rhythm in this case. I would treat the heart failure first. What do you think, Nizar?
Yeah, I mean the immediate symptoms is the heart failure.
Yeah.
If the patient has any signs that she is in dire straits, maybe low blood pressure, and close to, say, hemodynamic collapse, then I might actually consider cardioversion.
Yes.
But in situation where blood pressure is fine, I would probably think about actually controlling the heart failure and then finding what's the underlying cause for this actually.
Okay, so yes, somebody asked, is cardioversion a priority with such a big heart? Yeah, we were just discussing that. We think that the cardioversion actually would not be the priority in such a big heart. Treat the heart failure first. We have time, okay? I think it's important to treat the rate, okay? Maybe the patient will feel a lot more comfortable if you treat the rate. Don't need to rush into treating um, the rhythm. So cardioversion is not the choice here. If the echo, somebody asked, if the echo shows what is that? Heart EF during acute decompensation state, should we start patient on ACE as well? Okay. Again, I think our aim here is, of course, acutely, and then always think mid-term kind of treatment and long-term. ACE inhibitor, you can start, but you don't have to start immediately. Okay, you should start eventually if the echo shows poor LV function, because then you would think about treatment of heart failure, which we will go into. So the final diagnosis, okay, the patient actually has thyrotoxic cardiomyopathy with a very low TSH, okay, and the thyrotoxic cardiomyopathy may be the initial presentation. The cardiomyopathy may be the initial presentation in 6% of patients with hyperthyroidism. Means they did not present with any other symptoms that suggest thyrotoxicosis. Patients has acute pulmonary edema, congestive cardiac failure, and fast atrial fibrillation. That's our diagnosis. And treatment should be acute management, means treat the failure, control the heart rate if cardioversion is not possible. 10 to 25% of hyperthyroidism has atrial fibrillation, especially in the older age group. And then, of course, we must treat the thyrotoxicosis. Okay, so symptomatic treatment and acute treatment. Heart failure, okay, what do we use? Okay, because we want to treat the rate of, okay, because we want to treat the rate of the atrial fibrillation. So Jared asked whether we should treat the patient on ACE. I would actually start the patient on a beta blocker first. Okay, Nizar?
Yeah, I want to control the heart rate, right?
Yes. So in actual fact, some of the studies that used beta blocker as first choice compared to ACE inhibitor as first choice, both did just as well. So I think yes, eventually I would put the patient on ACE inhibitor, but I would like to maximize the rate control medication for the heart failure and the AF, and also the thyrotoxicosis first before I go on to ACE inhibitor. Another choice of drug is, of course, your ivabradine, which actually will reduce the rate, and also for long-term prognosis for heart failure, especially if the EF is less than 40%, you would like to consider, and then spironolactone. Okay. Then we go into rate control. Okay, now, Nizar, let's say now,
We've established this is a thyrotoxicosis, is it?
yes, we have established this is a thyrotoxicosis. I have not given the blood test for the thyrotoxicosis, but the diagnosis is thyrotoxicosis.
Okay.
Okay. So now, do we need to give amiodarone at all?
Not a good idea for this
Yeah,
person.
yes, not a good idea
Got a
because
thyroid problem.
yeah, and then
And
amiodarone can worsen the thyroid problem, possible.
I think
Okay.
a beta blocker here would be much more, I would say, appropriate. You can actually try and stop T4 from converting to T3 with beta blockers and therefore reduce the symptoms of thyrotoxicosis. Yeah, propranolol, somebody mentioned, is better because it's short acting and it's quick acting as well. So I choose something like a propranolol or to control the heart rate, and it's short acting, and if I need to stop it as well, I can stop it, and the washout period will be shorter too if it's necessary.
Dr. Kaur said, with such significant cardiomegaly, roughly how long the hyperthyroidism? Oh, it's very difficult to say.
Can be acute.
Yes, can be acute because they come with maybe a few days of atrial fibrillation and they can't tolerate it anymore. It can be acute, like like I said, I think the slide that I gave you before, it says that the cardiomyopathy may be the initial presentation in 6% of patients with hyperthyroidism. So it may be yeah, so we can't tell. Okay. If the patient has thyroid storm and atrial fibrillation, do we treat the atrial fibrillation and settle the thyrotoxicosis?
No, you treat the thyrotoxicosis first.
You can treat both actually.
And you
I
can
mean,
try and
it's all
control the rate,
patient.
yeah.
That's right. You need to think that we don't have to tackle one disease after another. So we actually can tackle both diseases at one go. So these are the things that you will learn as you go along. Yes, Ahmad said that propranolol is better, and then we have agreed on that. Sometimes propranolol, because it's good that propranolol is short acting, because we are not sure how the blood pressure will be like. If the blood pressure is low, and then we will be more comfortable using a short acting beta blocker. Sometimes when the LV function improves, then the blood pressure will improve with it. Okay. Any more questions? Okay. We go to the second case now. Okay. Okay. Second case is a 60-year-old gentleman, diabetes for 3 years, who is a smoker, came to ER with chest pain of sudden onset, sweating, and pain radiates to the left arm. Anyone? What do you think is the diagnosis that you need to entertain here? And again, it's an acute case coming to emergency. Yes, good. Everybody is thinking of MI. Okay. At least we know that we got people at the same. I think just now there was a question that Sylvester said. If the patient has underlying asthma, what would be the next option? For the fast atrial fibrillation, the next option would be digoxin. You can also use Corolan. But I think, sometimes patients, they are asthmatic when they are during a childhood asthma. Doesn't mean that acutely when you give beta blocker, immediately they will get asthma. I still think that you can try beta blocker. You can try short acting like propranolol. It should not be a problem.
Calcium channel blockers, they alternate.
Yes,
The
they are.
diltiazem, verapamil can also be considered.
Yeah. Okay. So your differential diagnosis is acute coronary syndrome. A lot of you have written there, or MI. What investigation is necessary, and what's the workflow forming in your mind now? Okay, I like to always make you think of the workflow that is forming in your mind, so that you can work quicker, faster, 2 steps ahead of everyone else. So now you have a gentleman with chest pain. So what is your working diagnosis, which many of you have said myocardial infarction? But what are the investigations that you would like to take? So of course an ECG. So what do you see here? Anyone?
Wow.
Can you see? Oh, you're still no video on my side. Okay. ECG
Yeah,
height
can see.
and size. Yes. ST elevation. Very good. Tombstone appearance. Don't say that because the patient is still alive. Don't use the word. I very pantang. So true. It's an acute anterior MI, maybe anterior septal. Okay. And so the diagnosis is obvious. And so this diagnosis is acute myocardial infarction, acute anterior septal, which is an emergency. And then the treatment of choice is primary PTCA, which is superior to thrombolysis. And then the door to needle time is the time from the arrival of patient to the time that the patient is giving thrombolytic or to primary PTCA. And that would actually determine the muscles that you are going to save. Okay, and then the muscle that you're going to save is going to determine the heart function of the patient eventually.
At the same time.
The time in essence is about 3 to 6 hours. So you need to know how. So when you see an ECG like this, before your consultant comes to do the primary PTCA, you need to know how to prep the patient for primary PTCA. You need to know how to take a consent, okay? And then you need to know what to give the patient, which must be immediate upon the diagnosis. For example, antiplatelet, okay? Thrombolytic if the cath lab is not available, beta blocker or ACE inhibitor, okay? Anything that, any questions here? No questions? Okay, no comment. We go on. Okay. While in ER, setting the line for the patient became unconscious with up-rolling of eyeballs. What is the diagnosis on this ECG? VF, very good. No, Torsat is wrong. Okay. I think Torsat, when you have a patient that is in AMI with this type of ECG, it's definitely VF. I mean, it's not going to make very much difference to how you're going to treat the patient, right, Nizar?
Yeah. You need to do what is necessary quickly.
That's right. Because as we can see here, the patient is already unconscious with up-rolling of eyeball. Now, what you need to do quickly, okay, you need to defibrillate. Okay. Forget about the anterior posterior because it's going to be difficult. Please always think of anterior apical and then defibrillate the patient immediately. Okay. It is important that you go. So in this case, identifying the ECG, getting the cardiac enzymes troponin T or troponin I, immediate call for action. Either call your senior or call your medical officer. Do a CPR, but defibrillate as soon as you can. Okay. Is there any benefit to antiarrhythmic drugs if you can defibrillate immediately? Not really, right? Okay, so
Not necessary.
not necessary.
What you need to remember in such a situation is this is a perfect storm. The patient is in acute myocardial infarction. There is cellular acidosis. There is disorganization of refractory periods, and it tends to develop these arrhythmias. So what's causing this is actually the acute myocardial infarction. So what the patient requires is actually immediate attention to that. And primary PCI will actually be the thing that you need to do.
Yes, this is very important. So revascularization is very, very important. Okay, antiarrhythmic drugs not so. Okay, so acute myocardial infarction is an emergency. Oh, we have done that, right?
Not yet.
We have.
Oh, is it? I thought we
Yes.
haven't.
Yes. I went too fast, I think, or maybe yes. So again, we mentioned that it's an emergency. So primary PTCA is superior to thrombolysis, and then please remember your antiplatelets, okay, your aspirin, either that or your Brilinta or Plavix, okay, please remember to load them, because when you do the primary PTCA, you need to send them too. So both this antiplatelet will change the outcome of the patient uh, in an MI with or without primary PTCA. Okay, a VT or VF during an MI usually occurs early in the ischemia. Okay, primary PTCA reduces the incidence of sustained VT or VF during the first 24 hours. Beta blocker may be useful and reduce all major cardiac events in all studies. And Amiodarone, on the other hand, there were no added benefit in the use of amiodarone long term. In actual fact, the outcome was worse with the use of amiodarone during the acute period. And of course, ACE inhibitor in anterior MI improves LV function and the prognosis of an anterior MI. How do you manage a VF or a pulseless VT? Of course, electrical defibrillation is the most effective treatment of VF. CPR were unlikely to convert your VF. Okay, speed of defibrillation is a major determinant of success of VF treatment, and then survival rate, okay, of patients with AMI the moment they have VF arrest, okay, reduce by 7% every minute you delay. Okay. So any question at this moment while we go and discuss the last one? Okay. There are a lot of questions. So yeah, Ahmad says that he needs to be sent to the cath lab urgently. In a GP setting, this is a very scary scenario. Call for ambulance. Our ambulance equipped with defibrillators. It depends on the ambulance you call, right? These days, I think more and more ambulance are more equipped. Yes, it is a very scary scenario. In a GP setting, okay,
You should
where
have
you
a
don't
defibrillator, right?
no, I don't think they have a defibrillator. If you do not have,
But
then
they
you
should.
have to have a CPR. Yes, you may need to. You have that automatic defibrillator, you know, the one that will inform you what to do next.
See, the issue with VT-VF in acute myocardial infarction is this: 50% of people succumb to the VT-VF.
Yes.
What people don't realize is quite a majority of them can be saved, and their long-term prognosis does not depend on how they present. Whether they present in VT-VF or they're stable, it still is actually the same. So it's actually, if you can get them out of VT-VF and in sinus rhythm and send them to hospital, their prognosis will be exactly the same as those people who can arrive to the hospital without developing VT-VF. Long-term survival is not dependent on whether you have VT-VF initially or not. It's just the way that myocardial infarction presents. So you should have a defibrillator in the clinic so that you can save these people.
Okay, is primary PTCA the standard for all AMIs now, preferably? Yes. And within the 3-hour window period, hopefully. Yes, so we like to do the primary PTCA, especially if the patient has VT-VF. It is life-saving at that present moment. Somebody asked, Luke asked, is it helpful to load patients with 80 milligram atorvastatin in the case of AMI? Okay. Of course, the use of any statin in a case of AMI will change the prognosis of patients long term. And the earlier you start the patient with statin, the chances of them getting another episode in the next year or two will reduce also. But I think this is not something that you would think of in this acute situation. Okay, you can always start the patient on this atorvastatin or any statin for that matter. Eventually, no loading. So the word loading is not correct. So you would load the patient with antiplatelet, but I don't think you need to load the patient with statin. Nizar?
No, I do give statin, but it's always something that I start immediately because there are suggestions that risk of restenosis and intervention is lower with statin as well. But it's not actually, it's a good idea because you're thinking 2 steps ahead. It's not something urgent, but I would usually do it.
Yeah. It is something that already built in us where we write the prescription
Yeah,
for the admission, we will put in a statin immediately. But it is not something that we would ask the patient to take in ER, so that will be part of a preparation for the
correct. Yeah.
yes, for the procedure. Sorry, when exactly do we send the patient to pay during the CPR and defibrillation? No, the moment the patient comes with the chest pain and you see the ECG with the ST elevation, you would already prep the patient for what? But as you're doing this, okay, you need to defibrillate. When you're sending the patient to the cath lab, you need to bring along the whole thing. Means the team needs to follow the patient to the cath lab. Okay, so in the lift, you may have to defibrillate the patient. Okay, during the procedure, while the interventional cardiologist is doing the ballooning, somebody has to stand by, also being prepared to defibrillate the patient. But once you actually revascularize the patient, then um, the chances of him going into VF is much less. And then you have to really consider using beta blocker in the patient if the blood pressure allows it. Any more question on this case? If not, we go on to the next case. Yeah. So this is an 80-year-old lady who came with 6 months history of near fainting episodes. What questions do you want to ask further? What signs to look out for, and what investigations? Okay. Anyone? Oh, history of trauma. That is
Yep, yep.
surprising.
I think they're thinking of lucid intervals in an 80-year-old.
Oh, I see. Hypoglycemia, anemic symptoms, true anemic palpitation, and yes, good.
But you can't ask for hypoglycemia. What you can ask for, are they on any medicine?
Yes, and
Hypoglycemic agents, isn't it? Yeah.
yes, especially your sulfonylurea.
Yeah.
Okay, so
Insulin or phenylurea.
underlying hypertension. Okay, family history of
Palpitation, chest
young
pain,
sudden
yes.
death. Young sudden death usually would have she would come at a younger age now. So if sudden cardiac death, usually they will come. But the giveaway here is the 80 years old. So her age, okay.
And then the long 6 months history as well.
You can't ask the patient, Gerard, history of arrhythmia. You have to prompt and probe, okay. So you need to ask specific questions like, okay, do you have palpitation? Do you have skip beats? So your question must be quite specific for the patient to answer. Okay, so we go on, yeah. So, okay, when you saw the patient, you asked for an ECG. Oh, very good. Luke said history of episodic bleeding, melanic stool. Yes, yes. Always think of that too. Okay, so this is the ECG that you actually get when she came to see you. Okay, can anyone comment on the ECG? Hold on, let me just see. Can anyone comment on the ECG? What do you think of this ECG? So actually, this ECG is normal. It's a normal ECG. Okay. Very frequently, you have patients who come. Maybe the P wave is a bit abnormal in some, but otherwise it's a normal ECG. And very frequently, you have patients who come in with neophatic episode. When they come to you, they are well. You can't find anything that is really remarkable. Echo is also normal. Okay. And then when you ask for a halter, this is what you find. Okay, everything else is normal. Okay, the blood pressure is normal, HB is normal, but when you ask for a halter, this is what you find. Can anyone tell me what she has? Oh, normal. Yes, normal. Anyone?
No, it's not WPW.
Okay, can I know what is a halter? Okay, so somebody wants to know what is a halter. Okay, Amalina, a halter is an ECG monitoring that we put on for a patient for 24 hours to detect their rhythm. Okay, so they wear it home, and then we hope to capture something that may not have been caught in the clinic. Means like when we did the ECG in this lady, the ECG is normal. But because she's 80 years old, we wanted to make sure that she doesn't have any other abnormality during the time that she's at home. So we put her on a halter. But this rhythm monitoring, there are many kinds in the market right now. You can even monitor a patient for, let's say, 24 hours, which is a halter. You can monitor the patient for a week. You can monitor a patient for months. Yeah, Nizar, you put in something recently to monitor a patient's rhythm for
3 years.
for 3 years.
Yeah.
Okay. Can you explain to us the device?
Well, if you're symptomatic every day, so you can do a 24-hour hold and should be able to pick it up. But if you're symptomatic only every weekly or monthly, then it becomes difficult to do and try and predict when an episode will occur. So you can implant a device that should be able to do the same thing. And that implanted device is like a holder that stores the abnormal rhythm in its memory bank. You can actually access that to make a diagnosis of what's causing the fainting spells actually.
Yeah, some people, some of these rhythm monitors actually send it to the cloud so that we can actually access it anywhere. So some people say sick sinus syndrome, yes, very good. Irregular pulse, yes. Pause, yes. So
But this is not AF, you know. This is not atrial fibrillation. What you're seeing is this group beating. So it's a form of atrial tachycardia. And what's happening is the group beating is suppressing the SA node because there's sinus node disease, right? So
yes.
it's causing suppression of the sinus node, and that's why you see the long pause that occurs, and that's probably what's causing her to have dizzy spells and fainting as well. So that's typical of sick
How
sinus
that is not AF, huh? It's so irregular.
It is, but AF doesn't occur in short bursts like that, you know.
Oh,
So
I
this
see.
is probably a form of rapid atrial tachycardia, and then that is suppressing the SA node, and that's causing the long pauses. So that's what.
Sinus syndrome does come with AF, right?
Yes, they do. They can develop AF as well as a result, you know, because of this rapid firing focus.
Okay. So we have done that. So treatment of this arrhythmia, we want to discuss the treatment of atrial fibrillation and the treatment of sinus pause. Okay, but patient then discuss with the family, and the patient and family say they want to wait and see. Okay, they want to wait and see. Then 6 days later, she came to ER with severe giddiness. Blood pressure was low. Okay, anyone like to comment on that? No, it's not third degree heart block. It's actually sinus pause.
With third degree heart block, you will see P waves and you will see QRS complexes beating at their own rhythm. So here you don't see dissociation of the P and the QRS. In fact, you see PQRS, right? Except that you see this long pauses when there's no P wave, neither is there QRS. So these are sinoatrial pause with no ventricular escape at all.
Okay, so now she has come in with pause, very long pauses. Okay, so now what are the choices you have? Of course, if you do not have facilities,
Guna
you
wifi
may.
Hamidah ke ataupun
Sorry,
asal dia tak
somebody
stable lah.
talking. I'm not sure who is talking.
Kau punya okey eh?
You can try atropine, like we've discussed before, right?
Oh yes, we can try
atropine.
atropine. Sometimes it works, sometimes it doesn't work.
Correct.
Yes,
Yeah.
yes.
And then while you're thinking, if you're thinking of actually putting in a temporary pacemaker, then you would then consider this.
Yes, because sometimes it all depends on which hospital you're working in, whether you have the expertise or the facility to do temporary wire, and then that is also one problem. And then what are you going to do while transferring the patient? So you think of transcutaneous pacing. It is just basically like the defibrillator patches that you put on, but then you can actually pace the patient accordingly. But it is a bit uncomfortable, I would say, right? Because is this you are actually generating electrical impulse to pace the patient. Of course, ideally, this patient should have a temporary wire in. This picture actually shows a temporary wire, but from the subclavian. I seldom do that these days. I always use the femoral vein. Nizar?
Try not to use the subclavian because that's where we're going to put in the permanent pacemaker.
Oh yes, but funnily, when we were taught, when I was training, we were asked to put into the subclavian. So the
people do that.
can walk around.
But then we need the access for the permanent pacemaker, see?
That's
and if that area gets infected, then you have a problem.
Yes, that's right. I don't do it anymore these days. But that was the picture that I could get. Okay, so the treatment of choice in this patient is, of course, a permanent pacemaker. This permanent pacemaker would be because it will help her with her bradyarrhythmia, which is the sinus pause, but it will also allow us to treat the tachyarrhythmia with medication, drugs. Because if we go on with this slide, okay, so a permanent pacemaker, usually scheduled electively, is a minor operation under sedation. The pacemaker is inserted beneath the skin under aseptic technique. Consent is needed, and then the skin is closed in layers. Not necessary for antibiotics, and the procedural time is 1 to 2 hours. So this is where the scar is, and it's quite an easy procedure. Okay. Now, sick sinus syndrome is where there's severe bradycardia sometimes, with sinus pause of 3 seconds or more. It is not necessarily just bradyarrhythmia, it's actually a tachybrady syndrome. Okay, and the patient may actually present with SVT, but more commonly with atrial fibrillation. Treatment of fast atrial fibrillation may be difficult without inserting a pacemaker. Of course, when you come to treatment of atrial fibrillation, we again go back to rate control, antiplatelet, or anticoagulation. And then a pacemaker can usually last about 10 years. Any question now? Yes. So yes, sinus pause usually due to aging. That's why the age was a giveaway. Nizar?
Yeah, the mode of there is two modes of presentation, 60s and the 80s. So it's the largest group is due to degenerative disease of the sinus node, right? Although you have underlying causes like toxicity, coronary artery disease, myocarditis. In that situation, they might present in the younger group. But in the 80s, they're generally due to degenerative disease. So it's related to age.
Related to age. Okay, I think that's all on our discussion. I tried to cover as much as I could from the slides that we have given and the talk that we've given the last two sessions. And next week, we will try to organize a quiz where you can actually respond with your handphone. We not being very tech savvy here, can't even get the video going. On my side, we need to work on that with Tan. Tan is actually
This is
helping
going
me.
to be a challenge.
So sorry. Any questions, please send us now. We'll take all questions, and thank you very much for participating. Maybe you can like to ask us some questions. If there's none, we will then wish you a very good weekend. And we'll see you next week. We will try to work it out again. Oh yes.
Somebody's asked.
Yes. Do you start anticoagulation for paroxysmal atrial fibrillation? Yes. Some mitral valve disease actually, yes, will have paroxysmal atrial fibrillation before they go into persistent or chronic. And if the LA is large, I would start anticoagulation, warfarin, especially if it's mitral stenosis.
For thyrotoxicosis, you should. There are suggestions that thyrotoxicosis increases the risk for thromboembolism. Yeah, they do. In some scores, thyrotoxicosis is one point actually. But in general, if a person with paroxysmal AF, then I look at the CHAD-VASc score. If their score is more than 1, then I would consider actually anticoagulating them.
The other
For
thing
valvular
is,
AF is different. Valvular
yes,
AF, you're not actually tied to the CHAD-VASc score. For valvular AF, atrial fibrillation, you should anticoagulate.
very paroxysmal or not, because in actual fact, when you have paroxysmal AF, you go in and out of atrial fibrillation. When you go into sinus rhythm, then it's even more likely that you will throw off an embolism, isn't it?
Yeah. Our current recommendation is not based on whether it's paroxysmal or persistent. Although there are data suggesting that people with paroxysms are less likely to develop thrombus. But in general, our recommendation is still that all cases of AF, whether paroxysmal or persistent, should be anticoagulated if they have enough risk factors to suggest that they are at risk. So that's the CHAD-VASc score, or if they're valvular AF, for example.
Okay, Ahmad asked if the CHAD-VASc score higher than the CAS-BLAD. Sometimes whether to anticoagulate or not.
Yeah. If there
It is
is,
also,
if your Hasblat score is high, for example, then let's say your Hasblat score is 6, which is unusual, but it's possible. Then you may have to think about other options in trying to prevent stroke. And these are in the realms of devices, actually. You have the left atrial appendage occluders, or a surgical method of tying off the left atrial appendage. But in general, even if the CHED-VASc score is equal to the Hasblat score, you may want to consider anticoagulation.
and I think it's all about one, counseling the patients and the family, and then the more you worry about the patient, I would suggest that you actually monitor the patient more frequently. So that is the main thing, so that you can actually gauge, okay, especially if the patient is on warfarin. I think that is what you need to do. Counsel the patient and then monitor closely. Anything else? Thank you very much. Okay, it would be more excellent if could have seen my face. But okay, I see you next week then. Next week we will organize the quiz. Definitely. Okay, have a nice weekend, everyone. See you. Bye. Bye, Nizar.
Bye.
I'll speak to you next week.